Hello everyone, this is I Will Teach You Medicine, and on the ENT series we are doing non-suppurative otitis media on today's video. So let's get started without any further ado. So the types of non-suppurative otitis media include otitis media with effusion or OME. The second is adhesive otitis media. The third is tympanosclerosis, and the fourth is barotraumatic otitis media. So otitis media with effusion, let's discuss that on the first out of the four. So otitis media with effusion or OME is the presence of serous or mucoid effusion in the middle ear cleft with no frank pus, right? So there is serous or mucoid effusion should be present in the middle ear cleft, and there should no and there isn't any kind of frank pus, right? So otitis media of effusion has like various names, right? It has synonyms. So they are secretory, ceremucinous, catarrhal, or gluer. Okay, secretory, ceremucinous, catarrhal, or gluer. So secretory or serous otitis media, right? And then ceremucinous or exudative. So many kind of like exudates are formed. So exudative otitis media, and then catarrhal otitis media or gluer. So these are the synonyms for the otitis media with effusion. So if anyone asks you a question not question, but they talk about ceremucinous otitis media, then don't get confused, because it is same as otitis media with effusion, OME at the end. So yeah, you should know that. So what causes otitis media with effusion? So it is etiology, right? So there are three etiologies. Okay, the first one being if the eustachian tube is dysfunctioned, right? What is the function of eustachian tube? To provide aeration, right, to the middle ear. So if the eustachian tube is dysfunction, it's not working well, then it can cause otitis media with effusion. So how does this work? So if there is a vacuum in middle ear, right? So if there is a vacuum in middle ear, so if there is no any kind of aeration in the middle ear, then what will happen? It will cause extravasation of the fluid, and in case of lack of drainage of the middle ear, there will be secretions. Yeah, middle ear secretion will be drained, can't be drained, right? So there will be lack of drainage of the secretions, that will lead to the eustachian tube dysfunction, that will lead to the otitis media with effusion. And the another one is URTI, all right, allergy or infection, upper respiratory tract infection or allergy. Okay, infection means due to viral causes. So it will what will happen? It will increase the middle ear secretions, right? So this is and another is that untreated, inadequately treated acute suppurative otitis media, ASOM, right? So these are the etiology of otitis media with effusion. So what causes ET dysfunction, right? So dysfunction of the eustachian tube. ET means eustachian tube, right? So the first one is obstruction. Okay, if the eustachian tube is obstructed, so what are the condition in which the eustachian tube is obstructed? They are due to the edema, that is intrinsic, and then some. So on the extrinsic, it can be due to any kind of adenoid tumor or nasopharyngeal tumor, or any kind of radiotherapy, after radiotherapy, post radiotherapy, scarring. Okay, so this is normal. So intrinsic cause, that is due to edema, intrinsic edema, that is due to infection, allergy, and trauma. And the second is extrinsic, that can be due to mainly tumors. Okay, that can include adenoid or nasopharyngeal or post radiotherapy scarring. Okay, so it's all written in here. And another one is ET obstruction. Okay, edema, extrinsic, and then functional, that can be due to the floppy eustachian tube. Okay, this condition for floppy eustachian tube can also cause eustachian tube obstruction. And the second one is the patulous eustachian tube. Okay, obstructive eustachian tube, and then patulous eustachian tube, PAT, patulous. Okay, PATULO, patulous eustachian tube. So it causes reflux of the secretion, so it can't drain properly, and then what happens? Otitis media with effusion. Okay, that is the eustachian dysfunction. And the third one is the palatal abnormality. Okay, in the patient with cleft palate and palatal palsy, the palate, the if it is any kind of congenital disorder, right, cleft palate, so that can also cause eustachian tube dysfunction. Okay, it can cause eustachian tube obstruction, yeah, dysfunction and obstruction mainly, right? And then another one is mucociliary pathology. Okay, mucociliary pathology means any kind of pathology, any kind of disease that is present on the mucociliary clearing mechanism. So it includes it can be occur due to infection, allergy, or smoking, right? Any kind of allergy, it's a main, it's very important aspect on this allergy. And then another is Cartagena syndromes, right, or Young syndrome. So okay, we will read about Cartagena syndromes and Young syndrome in the next slide. And then also surfactant deficiency and immune deficiency, right? So let's get down. So what is Cartagena syndrome? Okay, it is a Cartagena syndrome is, it's like a collection of disease, right? There are many disease happening going on in the Cartagena syndrome. So that includes ciliary dyskinesia, means the cilia. Oh, wait a minute, let's draw something. Suppose this is a cilia, right? I'm sorry for my terrible drawing. So yeah, this is kind of an epithelium, and here is a cilia, right? Again, my drawing is very bad. So this is cilia. So what does it do? Cilia, it will like beat, it will beat like on like a train belt, like this. It will belt, and what does it do? It clears away the secretions, the mucus, the viruses, the bacteria towards like outer part, it cleans, right? So if there is dyskinesia, means like ability to like loss of ability to like kinesis, means walk or a movement, right? So dyskinesia means it can't move. So ciliary, if this cilia, they have pathology, if they can't move, then we have Cartagena syndrome. That is the number 1 point. Another is situs inversus. So you may probably know this is a very rare condition, not so rare, but it is rare, right? Situs inversus. So what happens in situs inversus is, let me show you a photograph. So in the situs inversus, we can see this figure here. So normally, what is this? This is a normal human being, right? So they have like two pair of lungs and a heart on the left side, and then like liver on the right side, stomach, duodenum, ileum, jejunum, and all small intestine, appendix, long, like ascending colon on the right, transverse colon on the middle, and then the descending colon on the left, and then again rectum and all, cecum, rectum and all. This is the like normal configuration, right, where the organs are supposed to be. But in situs inversus, what happens is, look, just opposite, right? So there are two pair of lungs, it's accurate, but the heart is situated on the left, no, instead of left it is on right, right? And then the liver lobe, sorry about those, like the liver is on the left side, and then the stomach is on the, sorry, liver is on the, yeah, left side, and I got confused. The stomach is on the right, and the duodenum, jejunum, all that. So it's like placing a mirror in your organs, right? Look, like an image is formed just opposite, right? Yeah, so opposite, just situs inversus is this condition, right? Your organs are not where it's supposed to be, they change the location like just laterally. Okay, so that is situs inversus, that also seen in Cartagena syndrome. And the third one is bronchiectasis sinusitis. So bronchiectasis, you may have already learned about it in the pathology and the basic science. So bronchiectasis means permanent dilation of the bronchioles, the small alveoli and all. So they get permanently dilated, right? So if this is a normal histology, you know so in bronchiectasis, it's get like dilated like very abnormally, right? So bronchiectasis and sinusitis, that can also occurs in Cartagena syndrome. So these are the three collection of disease that constitute a Cartagena syndrome. Ciliary dyskinesia, the cilia won't beat properly. Situs inversus, the organs are like all opposite and all. And then the bronchiectasis sinusitis, that is the permanent dilatation, abnormal dilatation of the alveoli and all. And the another condition is Young syndrome, right? So in Young syndrome, we can see hyperviscous mucus. Viscous means what? Thick mucus. Hyper means more thick, right? So in Young syndrome, of course the mucus is thick, right? When you cough and all, so you will get a thick mucus. But in Young syndrome, that this is extra, right? Extra thick mucus. You would like to use that words to describe other thing as well, but and the another one is zoospermia. So spermia means sperm, and ozo means absent of sperm. So there will be no sperm production in a child with Young syndrome, and their cough will be hyperviscous. All right. So Cartagena syndrome means ciliary dyskinesia, situs inversus, bronchiectasis, sinusitis, and Young syndrome that contains constitutes hyperviscous mucus and azoospermia. So these all come under mucociliary pathology, and there will be other causes like surfactant deficiency or immune deficiency as well. So now, what are the yeah, this is again the same thing: causes of eustachian tube dysfunction, abnormal patency, patellus et, functional obstruction, any kind of functionally inflammation, and then tumors of the tumors or adenoid, right? So what causes a child to have otitis media with effusion? So that can be any kind of child, all right, to a nursery, not specifically nursery, but child, okay, this is the main keyword. And early weaning with formula milk. So formula milk, the children who have like formula milk who have formula milk, they are on like predisposing condition, okay. And then parents who smoke, all right, smoking is a risk factor. And then recurrent respiratory tract infection, right, URTI or RTI, it's very recurrent, right? And then crowded living condition, okay. Another one is poor nutrition, and then the cleft palate, palatal abnormality. So coming to the clinical symptoms, so what are the clinical symptoms a patient has when they have a otitis media with effusion? So otitis media with effusion, there will be like normal temperature or normal like abnormal pressure inside the middle ear, so that will cause some form of like conductive hearing loss, so there will be a mild deafness, okay, the degree of the deafness is mild, alright, in a young child. And then deafness increases during URTI, the upper, any kind of inflammation, that can in the upper respiratory tract infection, that can cause deafness, because many kind of edema can happen, right? And then inflammation can happen, so that will also cause deafness during the URTI. And the third point is the patient will have otalgia, means earache, right? And then blocking sensation in the ear, like we feel like we say in Nepali, kan damma bhayo, right? So blocking sensation in ear, that is also seen. And the another is delayed and defective speech due to deafness. So if a child is deaf, they can't properly make out the sense out of the word, right? So they can't hear, they can't receive the external stimulus, right, in the form of speech. So they will also have like delayed and defective speech pathology, okay. So we should like if a it is our duty to refer a child with OME, for a long time, to a speech pathologist, right? Speech pathologist as well, so we should also consider that, okay. So we can see here the child is very inattentive, and then earache, otalgia, and then blocking of nose, right? Now coming to clinical signs, so what are the signs a physician will see on the patient, right? So an otoscopy, this is a very dear instrument of every otorhinolaryngologist. Otoscopy, okay. So while doing otoscopic examination, we can see blue eardrum, okay. The color of the eardrum or tympanic membrane is like slightly blue, not exactly blue, but you can like figure out, with restricted mobility even after sigillization, okay. Even on sigillization, we can't see any kind of mobility on the tympanic membrane. And in the early stages of otitis media with effusion, there will be retraction of the tympanic membrane, retraction pockets can be seen, but in the later stage there will be a bulging, we can see, that is a clinical sign. And then we can also see the fluid level plus air bubbles behind the tympanic membrane, we will see a picture of that. And then while we perform like normal like routine checkup, otoscopy is done, then we do the tuning fork test. So what happens, the fluid is like exudative fluid that is like struck in the middle ear cleft, right? So it will obviously hamper the movement of the like all that tympanic membrane and then the ossicles. So what will we get a result, that is conductive deafness, right? So also on the finding we can interpret that the person has a conductive deafness. So on otoscopy, we can see here a doctor is seeing through otoscope inside the middle ear of the child, right? Sorry, yeah, in the tympanic membrane. So what are the features that he is seeing? So what he sees is, so this is what he's seeing, right? So we can like not so appreciate it, but we can see this is like yellowish and brown, so that makes it like blue, right? So the spectrum of the tympanic membrane is slightly blue, right? So we can see that bluish discoloration of the tympanic membrane. And then we can also see, like in the early stages, we can see the retracted tympanic membrane, right? So eardrum, so this is retracted. We that the doctor, this doctor right here is seeing. Suppose if this girl is the if this girl child has otitis media with effusion, then these are all the findings we are describing, right? And we can also see the air fluid level, right? In the right here, this is a right tympanic membrane, so we can see here it's all like air and fluid. This is all air and this is all fluidy, right? Little bit of blistering can be seen. And then yeah, we can appreciate more nicely on here. This is a tympanic membrane, so this is all fluid, and here is bubbles, so air. So air is to fluid level, right? So we can also see that. And then here we can more properly, like, see this is an bubble, 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 right? So this is a right ear bubbles, right? And then left ear bubbles, oh my god, this is more prominent, like you can see, like, make out of this all these ear bubbles. Okay, so these are the findings we can find. So investigation, what are we gonna send investigations to confirm, to give the like diagnosis that the person is suffering from otitis media with effusion? So we do pure tone audiometry, right? So in the PTA we will have another video about the PTA. So here what happens is, like, this 20 banda mathi, it's above 20 banda mathi, so it is like conductive deafness, right? Conductive hearing loss, CHL. And here we can see the low frequency conductive deafness, as it has been already discussed in this slide. So it is a low frequency conductive deafness can be seen on the PTA. And we can send for impedance audiometry at the same time, right? We will again discuss about audiometry PTA in the another video, another separate video. You can watch that. You can always find it in the ENT playlist, just in case if you are wondering. Okay, so we can send the audiometry, and then if it has a drum retraction, eardrum retraction or tympanic membrane retraction, we can see the C curve, right? C curve on the in the impedance audiometry. But if there is like only like effusion is only present, and then we can see B curve, right? B curve is seen. Okay, we will learn about all these curve: A curve, ASD, ASAD, BC curve. Okay, so also, so what have we sent? First one is PTA, investigations for otitis media, and then we have impedance audiometry, right? And the third is X-ray of mastoid of mastoid and nasopharynx, right? X-ray of nasopharynx. So we can also sometimes see there is a clouding in the mastoid ear cells, plus there is some kind of like adenoid mass can be seen, you know so how do we treat a patient with otitis media with effusion? So it's very, very, very important to use an antibiotic, especially amixiclab, right? Moxiclab. Okay, completely forgot how to pronounce it. Okay, so amoxiclab for 2 to 4 weeks. Okay, this is very important. And then we can use the nasal decongestant, that can be either systemic or topical. And then antihistamine, the H1 subtype, right? So this is very important. And then autoinflation of the eustachian tube by Valsalva maneuver. Okay, so we will also like read about Valsalva maneuver in the examination part. So yeah, please look at that video as well. And then for earache, we can always use analgesic, that is under the safe limit, right? So there are some non-medical or non-surgical treatment for otitis media with effusion, right? So no drugs, no surgery involved, but also we can like treat otitis media with effusion to some degree, right? So it can also include Valsalva maneuver, right? Okay, so first one is politerization, another one is auto-vent balloon, another is ear popper device, and then the other is ear dock device. Okay, so there are four, broadly classified into four types, four categories. Okay, politerization, auto vent balloon, ear popper, and ear popper and ear dock devices, right? So what is politerization? It is like a politza bag. Okay, this is a politza bag. Yeah, politza bag. So rubber tube attached to the polyester bag, okay, so this is the rubber tube, right? This is the rubber tube, RT. Rubber tube is put into the nostril. Okay, so this is patient's nose, one nose. Okay, nostril. There is another. Okay, that was a very wrong photo. I don't know how to make. Okay, this one. Okay, so okay, just this is, suppose this is a nostril, right? So the Pulitzer bag's rubber tube is placed on the nostril of the patient, and from outside you can always pinch, you have to close it. All right, so these are the nostrils, so you have to close this from the outside. So, and the patient is asked to swallow repeatedly, and the Pulitzer bag is squeezed simultaneously. You apply pressure as the patient swallows, right? So this is like a push device, like they use in like to clean the cameras and also put it in the bag. Yeah, so that can help for otitis media with effusion. So that is the technique of use. And this is auto vent balloon device. So it's literally nothing, that's just a one small like tube like device, and then here's a balloon, and it comes with lots of other white colored balloons, right, as shown in the figure. So see, what is this child doing? So he's blowing the air, right? He's blowing the air, and then what happens is he's inflating the balloon. So balloon is inflated by blowing air out of the nose. When fully inflated, balloon neck is pinched off, and the nasal occluder is inserted into one nostril. So yeah, so this occluder, it is inserted into one nostril, and then child is instructed to swallow as the balloon deflated into the nasal cavity. Okay, so swallowing is very important. So the patient swallows as like the autovent balloon device is deflated into the nasal cavity. So portion of the air from the balloon enters eustachian tube, and the air will literally ventilate the middle ear, right, middle ear. So there will be like no any kind of otitis media with effusion. So it is also a non surgical, non medical treatment, right? And here comes now fancy devices. Okay, so this is a air popper device. So what happens is you put your air popper device into one nostril, same like auto vent balloon, right? So yeah, this is like Pulitzer maneuver, same, but it is like automated. So device delivers a safe, constant, regulated stream of air into the nasal cavity, just like a Pulitzer maneuver, right? So it regulated stream of air into the nasal cavity, and then during swallowing, air is diverted into the eustachian tube and clear and ventilating of the middle ear. So main aim is to like clear and ventilate the middle ear, right? And then there is one device that is known as air duct device, right? So air duct device, what happens is it generates and transmits a special vibration waves. Okay, so this is like more fancier. Okay, the air popper used to like just only like stream the air, but the air dock device, it what does it do? It radiates, it generates, it transmits the vibration wave through the temporal bone, right? So is look here, the patient is like putting the air dock device over the temporal bone, and it reaches the middle ear. Okay, so middle ear and the eustachian tube. So what happens, this will the waves, the vibratory waves will ease the middle ear pressure, and then it drains the trap fluid. Okay, whatever fluid is there, as a result edema and pain are reduced. So yeah, that's that. And so now, okay, that is non-surgical. First we read about medical treatment, and then non-medical, non-surgical, this is the gray zone. And then we, after all this didn't work, so we have to do some surgical treatment, right? Surgical treatment as well. So this is very important, right? So this is we do is myringotomy, that is tympanocentesis, also known as myringotomy, is also known as tympanocentesis, and then grommet insertion, that is pressure equalization tube. So grommet, what does it do? It will like equalize the pressure. Okay, so what happens here is radical incision made in the radial, sorry, not radical, radial, right? Right, radially the incision is made in the anterior inferior quadrant, right? And AI. Okay, so this is a tympanic membrane, so we divide it like this, right? Write this. So this is the anterior superior, anterior inferior, this is the posterior inferior, and this is the posterior superior, right? So in the anterior inferior space, anterior inferior what is that called, quadrant, yeah, quadrant. So we can do here is like we can put an radial incision, right? So we will see that on the below as well, radial incision. Yeah. This is the radial incision, right? Yeah, we can see it more here. Look, radial it is incised. Okay, we will learn about it later. So yeah, it is done in the radial incision, okay, in the anterior inferior quadrant. But if the thick is fluid, then two incision are made, that is anterior inferior quadrant and anterior superior quadrant. This is known as the beer can principle. Okay, radial incision in the anterior inferior quadrant if the thick isn't like if the fluid isn't thick, but if the fluid is thick, then we have to do two incision, that is on the anterior inferior and anterior superior, and you know that it works on the beer can principle, right? So another is laser or radio frequency assisted myringotomy. Okay, so laser or radio frequency assisted myringotomy. So here what happens is, like, we use laser or any kind of like laser frequency, you know, it is a hi-fi device. Okay, and we use for grommet insertion. No, like we just do a myringotomy, but there is no grommet insertion required. Another one is cortical mastectomy, that is for refractory cases with loculated fluid in the mastoid. You know, cortical mastectomy, if the case happens over and over and again, then we have to do refractory, we have to do cortical mastectomy. Okay, and it should be loculated fluid in the mastoid. Okay, and then anyway, if we remove the predisposing factor, then otitis media with effusion is not going to takes place in the first, you know, in the first hand, right? So we do predisposing factor treatment, that is adenoid or tonsillectomy, and then antral was or polypectomy. Okay, that can also cause otitis media with effusion. So let's like surgical. Okay, this is a myringotome, this is a very sharp blade. So this is a myringotome instrument. So right myringotome incision, yeah, radial incision can be seen, and this is the left myringotome incision. So what is this? This is a right sided tympanic membrane, right? So this is the umbo, here is the manubrium of malleus, and then air fluid level meniscus can be seen. So look here, we are doing a myringotomy as well, right? So look at this is a beer can principle, right? So here it is done in the anterior superior and then the anterior inferior quadrant, and this is what like fluid that otitis media with effusions looks like. This is a glue like fluid, right? So now let's talk about some type of grommet. Okay, so there are so many types of grommet, out of which they are Shepherd's grommet, you know, the donut like, it's a normal type of grommet, sorry for my drawing. And then this is Armstrong's grommet, Shepherd's, Armstrong's, Donaldson, and Shaw's. Okay, Shaw's, this is like I have seen it so much time on the internet, right? It's like a shoe, so Shah. And then Donaldson means it's like a donut. Okay, Donaldson. And then Donaldson, and then Shepherd. Okay, not on the both side Donald, but only one place. Okay, and then we have Armstrong, so this is like little bit of curved, and then, you know, the donut again. So Shepherd, Armstrong, Donaldson, and then Shah's grommet. And then there is also another new type, not new, but this is also a type known as T-tube grommet. All right, so what is done? Grommet is inserted into the tympanic membrane to equalize, that acts as like a medium to equalize the pressure in the both of the cavity, in the cleft, right? So you know, grommet is inserted, and then we can see, yeah, you know, this is like Shaw's, I think, yeah. So right grommet is inserted in position, you can see, and then we can see another grommet inserted into the left tympanic membrane, and then in the anterior superior quadrant, this is the anterior inferior, right? So grommet in the anterior superior quadrant can also be seen, and then T-tube, yeah, T-tube grommet is in situ, right? So this looks a lot painful, but it isn't. It is very comfortable, and so this is a very good a figure. You know, how does the grommet like comes out? You are not going to like take out grommet individually, right? So extrusion. So grommet gets extruded on its own due to endothelium growing. So these are the three layers of the tympanic membrane, and we have like inserted a grommet successfully. So what happens, like it will cause aeration, right? So otitis media with effusion, like drainage and the pressure will be equalized. And so after this you know, what happens is there the endothelium that will overgrow, okay, over the grommet. Okay, so it will grow, and what will happen is like it will eventually push the grommet, okay, and on its inner. Okay, so let's read what the slide said. Grommet gets extruded on its own due to endothelium growing on its inner surface. So extrudes after 6 to 9 months. Okay, so it normally occurs, so you don't have to like do a surgery again to take out the grommet. Okay, so this is like happens. Look, see, the endothelium has grown over 6 to 9 months, and the grommet is like it has like come out. Okay, so we can also see some type of like heel tympanic membrane here. some healing process has occurred here. And then okay, that was the treatment, right? Grommet insertion. But what are the complications? So it has a price, grommet insertion has its price, not the actual price, but also like theoretical, like in words it has a price, right? So tympanosclerosis, okay, so what happens, it becomes tympanosclerosed, okay, it will become sclerosed, so chalky white color we can see in the in the tympanic membrane. So that is caused due to the sclerosis occurred due to the grommet insertion. And sometimes it is not necessarily that it will heal, but it will like complicate the tympanic membrane, okay, so it will cause perforation, right? Tympanosclerosis, tympanic membrane perforation, see again perforation we can see. And then you can see some type of like granulation tissues are formed over the grommet, right? So that is also an complication. And then sometimes the grommet gets lost inside, right? It will get lost inside, it will like remain inside only. So yeah, that's what happens. So what is the sequel of otitis media with effusion? So it is either like tympanic membrane atrophy and atelectasis, and then adhesive otitis media, and then tympanosclerosis, and sometimes cholesterol granuloma deposition. And then sometimes it can also cause ossicular necrosis, right? So incus malleus and stapes, they can happen like necrosis. And then retraction pocket and cholesteatoma can also be seen. And another, what is the another point, that we can there are something like which we can do to prevent otitis media with effusion. They are avoid irritants like cigarette smoke, do not smoke, yeah. And then if you have any kind of allergy, then identify and avoid allergies. And then consider a smaller day care center, that is like small any kind of like children who that has like less than 6 children, that can cause, like, because it is not crowded, right? So overcrowding is also one of the risk factor or predisposing factor for otitis media. And wash hands and twice frequently, and then use air filters and provide fresh air at home. And then we have to like encourage breastfeeding rather than the formula milk, right? And then use of the pneumococcal vaccine as well. So this includes the otitis media. All right, so now we will discuss about adhesive otitis media. Okay, adhesive otitis media it includes like tympanic membrane atrophy and then atelectasis, right? So this both happen, and then like this will cause adhesion in the middle ear cavity following chronic otitis media with effusion. So after otitis media with effusion for a long time, what happens is like tympanic membrane will go under atrophy and then atelectasis. Because why does it happen? It is due to the dissolution of the fibrous layer. That is the MCQ question. Okay, so in adhesive otitis media, the main pathology is tympanic membrane atrophy with the atelectasis due to the resolution of the fibrous layer. And then what happens, it will like adhese, right? It will like get stuck, like a fevicol. So the adhesion will take place in the middle ear cavity, that will occur due to the chronic otitis media with effusion, right? So what are the clinical features? So clinical features include conductive hearing loss or conductive deafness. And then there will be thin retracted tympanic membrane with no mobility, right? There will be retracted tympanic membrane with no mobility. So because it is adhesive, right? So it has like stuck, right? So there will no mobility, right? So you do whatever, there will, okay, there will be no mobility we see. And so we can see this is all like tympanic membrane is like atrophied and atelectasis, and then it will get adhesed to the adhere to the middle ear, right? So treatment, what are the treatments? So we can always use hearing aid, and then surgery, right? We can use hearing aid or the surgery. So in surgery there is the long term results are very poor. So that surgery includes tympanotomy, and then that will like tympanotomy then release the adhesion, plus put silastic sheet between the promontory and the tuber, like we have to, like we are putting a sheet, that silastic sheet between the promontory and the tympanic membrane. So like the adhesion is like broken off, and then we can also do grommet insertion, right? So yeah, this is left grommet in position, and all that. Okay, so tympanosclerosis. So what is tympanosclerosis? It is like a deposition of the hyaline, that is acellular avascular collagen. Okay, hyaline, that is avascular and acellular deposition, and plus calcium deposit in the submucosal tissue. Okay, so there will be a calcium deposit in the submucosal tissue of the tympanic membrane and middle ear cavity following a long standing otitis media. Okay, chronic otitis media. So what is the treatment of tympanosclerosis? It can be hearing aid, and then the surgery can be done, sclerosis, like chalky white color in the tympanic membrane we can see. So remove the tympanosclerotic plaque and perform tympanoplasty. So we will like cut this off. We will cut this off, we will cut this off, and then we will perform another graft, and then we will do tympanoplasty, right? So we can also do that. So now next, very small but important topic, this is the barotrauma of the middle ear, right? So what happens is, in the barotrauma, the eustachian tube has like collapsible, like cartilaginous part, right? So there are two parts in the eustachian tube, right? So one is like vulnerable to collapse, that is cartilaginous part, and then another is rigid bony part, okay? So what happens is, allows expulsion of air from the middle ear into the eustachian tube, but not suction of air into the middle ear cavity via the eustachian tube. So this is what happens in the like pathogenesis, okay? So what happens is, this is in middle ear, right? And this is like eustachian tube. So middle ear has like positive pressure, right, in the middle ear. And so when a patient is accenting, there is a positive pressure, so the air will go from middle ear into the eustachian tube, because the pressure is negative in the eustachian tube. And in descent, what happens is, like, the pressure is positive on the eustachian tube, but in the middle ear there is negative pressure. So descent, eustachian tube goes into the middle ear, right? So we can always see that. So what this part means is, so in like barotraumatic barotrauma of the middle ear, so what happens is, like what happens is that it allows the expulsion of air from the middle ear into the eustachian tube. So this can happen, right? But there is no suction of air into the middle ear via the eustachian tube, right? So from here it cannot go inside in the middle ear. So that's what causes the barotrauma, right? I hope that made sense. So etiology, so it is the failure of eustachian tube to equalize rapid increase in the pressure difference between the middle ear atmosphere over the long period, okay? So it is a failure of eustachian tube to like equalize rapid increase in the pressure difference, okay? So there will be pressure difference, so like it will have failure. So that what happens, that is the etiology, right? So during ascent, middle ear pressure is more than the atmospheric pressure, right? So there will be no barotrauma in the middle ear, normal middle ear, right? So if you are ascending, right, ascending means चढ्नु माथि प्लेनमा जानु, so middle ear pressure is more than the atmospheric pressure, so there will be like no barotrauma. But during the descent, what happens is, the middle ear pressure is less than the atmospheric pressure because the plane is descending down, so what happens is barotrauma occurs. So we have like chart, so pressure difference and the pathology in the middle ear, and then symptoms, okay? So if there is a pressure difference of -60 millimeter of mercury, then we can have hyperemia plus edema plus exudation plus tympanic membrane retraction. So symptoms include otalgia, deafness, and tinnitus, okay? And then there will be a difference of 90 mm of Hg, that is less in patient with cold, okay? 90 millimeter of Hg. So pathology, what happens is, like, the collapse of the lumen in the eustachian tube, that is the locking of eustachian tube occurs. So there will be microscopic hemorrhage, right? And then we have a symptom of severe otalgia. And if the pressure difference is of 100 to 400 millimeter of mercury, then that will cause like rupture, right? And then frank blood and otorrhea presents as a symbol. So these are the like pressure changes over time, pressure changes and the symptoms, how they progress. So at 60 mm of Hg, nothing was happening, right? So hyperemic eustachian tube with edema and retraction, exudation, and then tympanic membrane retraction that was occurring, and symptoms were also mild, like otalgia, small degree of otalgia and small degree of CHL, and then tinnitus. But as the like pressure difference increased, -90 mm of Hg, so there will occur like collapse of the lumen, that is locking of the eustachian tube will occur, and then microscopic hemorrhage can occur. And then the symptom has also like improved on the severity, right? So severe otalgia occurs, 60, 90. Now let's go to 100, -100 to 400. So there will be a rupture of the tympanic membrane, that will be a pathology, and then symptom will be frank blood otorrhea, right? So how do we treat barotraumatic ear trauma? So we have to use like nasal decongestant to make the aeration possible, and then H1 classification of antihistamine, and then like for a middle ear aeration we have to do polyterization catheterization, and then we can also do myringotomy and grommet insertion if the case is of refractory, and then there is a presence of hemotympanum, means a presence of blood in the tympanic membrane, right? So how do we prevent otitis media, like barotraumatic, so what happens is avoid air travel during cold or nasal allergy. So if you have a nasal allergy, then please be careful that you can develop barotrauma. And then during descents while flying, do not do repeated swallows, so lozenges and gum, okay? So while you are traveling in Nepal, like through like Yeti Airlines or Buddha Airlines, so they always offer small candies, right? So they offer small candies, Buddha and Yeti, you know Yeti. So they, why do they give that, to make us happy? No, of course no. We are like adults. We don't need chocolates to be happy. But they do that so that we can like swallow. While we are eating on those chocolate, we are eating those chocolate. Then we will do swallows. So it can prevent the barotraumatic ear trauma, right? So we have to do, if there like recently due to the COVID-19, they have stopped like giving the chocolates. Probably due to the like fear of spreading infection more. But we have to, even if they do not offer us the chocolate, we have to do the repeated swallows, right? So we can swallow like our thuk, you know spit, and then we can prevent the barotrauma. Another is we can do intermittent valsalva maneuver, okay? So if you don't know what a valsalva maneuver is, go look at it. You probably had done it. It's just a fancy name, and I will probably make another like clinical video about it, okay? And avoid sleeping, because in sleeping swallowing is decreased, okay? So this can also cause barotrauma. And then if the patient has a previous episode, then the patient should like always take nasal decongestant plus antihistamine before 30 minutes of descent, before descent. So while the plane is on air and the pilot announces, ladies and gentlemen, we are descending now, so what does the patient with like recurrent episodes have to do? They have to take the nasal decongestant, right? And then antihistamine before the 30 minutes. So these are the prevention of otitis, of barotraumatic barotrauma air, right? Barotrauma of the middle ear. So that's it, guys. I hope you liked it. If there was any kind of like mistakes I have done, please point it out in the comment section, right? And if there is like any kind of improvement, place of improvement, then please do suggest me on the comments. And if you like this series or these videos, then please like consider subscribing and hit a like. Yeah, thanks. That's all for this video.